So what do we mean by cure? Are we talking about no evidence of disease after a therapeutic intervention at 5 years, or just a 5-year survival rate while on therapy? Given the historical 1% 5-year survival rate, I'm going to put them together. I'm going to lump this. I'll take what I can get. If someone's doing well years on a particular therapy, it's akin to taking a blood pressure medication. And if it's working, it's working. And that's a win in my book. So, why are we excited about immunotherapies and why are we incorporating them into treatment for non-small cell lung cancer? Well, everyone's heard this. You've heard this all morning. We've kind of hit a plateau with chemotherapy. Targeted agents, not quite so much, but we are plateauing in some areas. But with immunotherapy, we're seeing something different. And we've seen it in other tumors, specifically in melanoma, where we're seeing these not as robust a response, but durable responses, which leads to survival benefit of years. For example, in melanoma, with CTLA-4, you can get a 20% 5-year survival rate and a 19% 10-year survival rate. And more recently, with the utilization of PD-1 inhibitors such as pembrolizumab, you can see even improvements upon that in terms of responses and duration of those responses and survival benefit. So the idea behind this is that we're bending the survival curve. We're looking at immunotherapy as a tool to change the way patients' outcomes are, or change patients' outcomes essentially. So instead of getting these deep, robust responses, we're getting responses, maybe not as much as we'll see with an EGFR inhibitor and EGFR mutant positive patients, but we're seeing these responses that when they occur, they're very durable, lasting literally not just months, but years. And so this is some of the data that we have. And one other caveat, we don't have 5 years worth of data we can look back on and say, here's a 5-year survival rate, or certainly don't have 10 years either. So the data we're going to be looking at is from phase 1 studies and some of the recently reported phase 3 studies. But be that as it may, in this phase 1 trial with nivolumab, you'll see that the 1-year survival rate was about 42%. And that number keeps repeating itself in the other studies that you'll see in a bit. The 2-year survival rate was 24%, and you'll see down here at 3 years, 18% of the patients in a heavily pretreated patient population were still alive at 3 years. And actually, if you look down there, it goes out to about 4.5 years, and more than 10% of the patients are still alive 4.5 years out. And remember, the historical survival rate for 5 years is 1%. So this looks very promising, and this looks like we are curing patients. We're seeing activity in patients that we generally don't see activity in, patients with high mutational burden, patients who are heavily pretreated, but we're seeing these responses on the order of 19, 20%, and they're very durable responses. And so here's what kind of defines what you see with the patient who's getting treated with nivolumab. Now this chart here divides patients getting treated, and then in the gold portion, this is duration of response after they start treatment. So as you'll see that this works in heavily pretreated patients. More than half the patients in this trial were getting 4th or 5th line therapy. B, activity is seen in both squamous and non-squamous. Responses last for months and sometimes years. We don't see that with other therapies, especially when the therapy is stopped. And they have ongoing responses still from this trial, which are over 3 years, and the patients are still responding. Some of them are off therapy, as you can see. So that's a phase 1 study. There's subsequent trials. This is a phase 2 study in squamous cell carcinoma. Again, the take-home message here, the 1-year survival rate is 41%. Very good. And when we move on to the phase 3, checkmate 17, which was in squamous cell carcinoma, again, you'll see this 1-year survival rate at 42%. This number keeps repeating itself. 2-year survival rate is over 30%. And this is in an unselected patient population, not PD-L1 positive. When you look at the PD-L1 positive patients, you'll see the duration of overall survival goes up in those that are very high expressors. And then the response rates were double that seen with chemotherapy. And again, I'll take you down to the median duration of response. It was about 8 months for docetaxel, 8.5 months rather. But for the patients who received nivolumab, 20% responded roughly, and the median duration of response was not yet met. So in other words, people keep responding. I think they're more than 21 months out at that point. So in the other trial, which was in the non-squamous group, similar story, high response rate approaching 20%. Duration of response was about 1.5 years. 17 months and change. And then again, we see actually a little bit of a higher overall survival at 1 year, 51%. It drops down to about 24% for 2 years. But then when you look at this based on PD-L1 expression, it's over 40% 2-year survival rate, 40%. So that's what we're getting with single agent therapy. Now the field's moved forward. So we saw that we have 1-year survival rates between 40 and 50%. We see that in unselected patient population between 24 and 30% 2-year survival rates, out to 18 at 3 years, and at 4.5 years, 10%. In the PD-L1 positive, it got as high as 40% at 2 years. Very, very robust, very exciting. But now the combinations are here. And in melanoma, they've shown that, IPI versus Nivo versus IPI-Nivo, the combination wins. So CTLA-4 plus PD-L1 works better. And that's now being looked at in non-small cell lung cancer. This is Checkmate 12, which has reported some data. And this is a small trial. A number of different schedules were looked at with this in the frontline setting. Take home is you see responses ranging between 13 and 39%. Over here on the right, you have nivolumab is kind of a standard. You see it's 15% in this patient population. And then when you look at it by PD-L1 expression, those responses go upwards almost at 50% if you're PD-L1 positive, 50% with immunotherapy in the frontline setting. And even in those that are PD-L1 negative, you're seeing still between 15 and 22%. And for those of you who are more interested in looking at pictures, you can see here that greater than 1% expression, you see tumor shrinkage in about 68% of the patients. So very robust activity with this new combination, and that's in the frontline setting. And in the second line setting, we're seeing a very similar thing. This is with pembrolizumab plus CTLA-4, and you can see that over 70% of the patients who were treated with this in the second line setting had shrinkage of tumor. And there was very durable shrinkage as well. And that's just with those two drugs. There's a whole plethora of compounds out there looking at LAG-3, GITR, IDO, which was just discussed. A number of different compounds out there. Combination therapies are being looked at, and even triplets are beginning to be looked at, as well as combinations with chemotherapy and with other targeted agents. I didn't mention this, but there's data now in the frontline setting. Again, small numbers, roughly 30 patients, where you have a CR rate with doublet chemotherapy and PD-L1 inhibition of about 10%, complete response rate of 10%. Response rates are in the 60 to 70% range of those patients. So lots of activity going on out there. Take-home messages, we are improving outcomes for patients. And so in conclusion, are we curing stage 4 lung cancer? Based on the data that we have available, you have to say yes. Remember, 5-year survival rate is 1%. We're seeing based on this data that we're getting out to 10% at 5 years. We're getting 2 and 3-year survival rates ranging between 30 and 40%. We have durable responses. Not everybody responds. Not everyone's going to get immunotherapy. There's some contraindications, but those who do benefit from it richly and deeply. And looking forward, there are numbers of different combinations which are going to be employed. And I think that these combinations are going to be the thing that unlocks this even further and allows us to really put a stamp going forward that we're curing stage 4 lung cancer. And I hope you believe me.